Hello, let's talk about esophageal diseases. In order to do so, we have to understand our approach to the patient with dysphagia. What is dysphagia? Well, it's a symptom, not a sign, so it's a subjective report by the patient. It's a subjective experience of difficulty swallowing. Whenever you swallow a bolus of food, you know it has to go over your tongue, and then it goes down the oropharynx, and then it goes into your esophagus, which is about 1.5 feet long or so, and then it passes from your esophagus into your stomach, and that's the full cycle of a swallow. And initiating a swallow, you know, that's an active process, that's a conscious process, but at a certain point, automaticity takes over, your body takes over, and you don't have to think about swallowing your food. So the esophagus is where swallowing becomes automatic. So dysphagia, you as the practitioner understand from this symptom that something's up with their mechanical pathway of swallowing. Something's causing them to not swallow properly. That's what dysphagia essentially is the patient is telling you that they've got uncomfortable swallowing. And your first thought should be, well, okay, where is this dysphagia? Tell me where it is, and have them point to it. You know, be as specific as possible as to where they feel, because again, it's subjective, it's a feeling, where they feel they're getting hung up on a swallow. Because where you're going to take your diagnosis is going to be very, very different if it's a problem up here, you know, in the cervical region compared to down here. If you've got a thoracic esophageal problem, then you're going to be looking at a very different spectrum of diseases than things that could cause dysphagia of the throat. So that's your first point. Another important consideration is this an acute or a chronic dysphagia, difficulty swallowing? Because if it's acute, then right off the bat, you're thinking obstruction, because it will be an obstruction most of the time. And so you ought to be treating acute dysphagia out of nowhere as though it is an obstruction, a foreign body or some sort of object in the esophagus until proven otherwise. And then finally, another good history-taking question to ask is this a dysphagia to solids, a dysphagia to liquids, or a dysphagia to both? And so solids is obviously something like crackers or cereal or a hamburger. You know, you chew up your food, you swallow it, and then at some point in the pathway down to the stomach, you feel as though that food gets obstructed somehow. Dysphagia to liquids, same thing, but it's when you take a drink. And a dysphagia to liquids does not mean like, oh, you chew a little bit of your meal and then you drink something and your meal's getting hung up. No, dysphagia to liquids means you haven't eaten anything. I'm going to give you a cup of water and you have a really hard time swallowing that. That's a dysphagia to liquids. And really the only disease that we see dysphagia to liquids in this SDL is called achalasia, and it's a problem with peristalsis. It's a problem with the contraction of the muscles of your esophagus. So this is a good time to transition into talking about the esophagus itself. It's a long tube, and it's whenever we talk about the esophagus, we map it out in thirds. And so the upper third or so of the esophagus is striated muscle that I'm trying to draw in with some striations or lines. And then the bottom 2/3 of the esophagus is going to be smooth muscle. Now you have linear muscle going all the way down your esophagus to the stomach. And then you also have some circular muscles that wrap around the esophagus circumferentially. Maybe I'll try to draw that in a different color. And the reason why you have these two different directional patterns of muscle in your entire GI tract, not just your esophagus, is so that you can conduct peristalsis. And how that works is that first, one of these circular radial type muscles is going to clamp down on the esophagus. And so if you've got some food, let's say right there, well then this circular muscle is going to clamp, and then the longitudinal muscle is going to contract and push that circular contraction forward, and that pushing moment down the length of the tube, no matter where you're at in the GI tract, that's what creates peristalsis, which is the forward propulsion of digested material down the directional gastrointestinal tract. So that's the sequence of peristalsis. First, you get your circular contraction, then you have your longitudinal contraction. And when you combine those things, you can bit by bit, section by section, push food all the way out your butt. So let's get into some specific esophageal pathologies. The first ones we're talking about are esophageal rings and webs. And I want to preface all this by saying we don't precisely understand the biochemistry or the pathophysiology behind esophageal rings and webs. They are findings, and we have observed rings and webs in many patients, and we know some things about them, but not everything. I want to go to the etiology section first because, again, it's helpful to understand what these things are before we talk about any anatomy or associations. An esophageal ring, the pathogenesis is controversial. You could get it because of GERD, and that might be called a stricture. And whenever you get a stricture due to acid reflux, what's happening is that acid is causing injury to the internal epithelium of your esophagus, the lining of your esophagus. And so just like you get granulation tissue that grows up and scabs up on top of a scratch or a scrape, you're going to get this sort of proliferating inwards inside your esophagus whenever there's injury to it. And so the reactive hyperplasia of epithelial cells lining the esophagus can generate a sort of ring of tissue around it, and that's going to be your reactive stricture. Now, there's a particular type of esophageal ring called the Schatzki ring, and it's found in a particular place at the squamo-columnar junction. And these Schatzki rings are almost always associated with hiatal hernias. And a hiatal hernia occurs whenever your stomach bulges upwards through the diaphragm. And if we're looking at this x-ray here, I'll draw a dotted line in this middle picture about where the diaphragm is. Right there. That's very, very important to understand that the esophagus has to pass through the diaphragm in order to get into the stomach. And so if part of the stomach prolapses from the abdominal cavity into the thoracic cavity, it has to do so by going through the diaphragm. So that's a hiatal hernia. And that can be another cause, we believe, of esophageal rings. Now, an esophageal web is kind of similar, but it's not an esophageal ring. A web is purely membranous in nature. It's got a mucosal component, but it does not have a smooth muscle component. Esophageal webs are diagnosed most commonly on endoscopy. It's pretty tough to catch these things on a barium swallow unless it's a rather large web. And the pathogenesis of esophageal webs is also unknown. However, we understand that esophageal webs are associated with iron deficiency anemia, and particularly the presence of a web in conjunction with anemia is called Plummer-Vinson syndrome, and that's something you ought to know. So rings and webs both cause dysphagias. The subjective experience of a difficulty swallowing. Webs tend to be your upper proximal esophagus, and rings tend to be your distal esophagus, felt in the lower chest retrosternally. And remember, your esophagus is behind the heart too. So that's important to know. And that can, if you're going to remember one thing, I guess remember that the webs tend to be up here, and the rings, especially the Schlotsky ring, which is the majority of rings, those are going to be way down there near the diaphragm. So understand that. This right here, good cartoon of a Schottky ring. Again, your it's going to be marginally above, couple inches above the diaphragm. It's got a characteristic location, and these type B Schottky rings do account for the vast majority of esophageal rings, and they're associated with hiatal hernias. So know the associations with each of those. Again, esophageal webs associated with this Plummer-Vinson syndrome, defined as dysphagia, iron deficiency anemia, upper esophageal webs. That's it. That's it, really. And they're going to have to work it into the question somehow that the patient has anemia. I saw a practice question where they just straight up told you the patient has difficulty swallowing and iron deficiency anemia. And it even told you that there was a narrowing in the upper third of the esophagus. And then it said, what's the most likely diagnosis? And a couple of the other answers were like esophageal ring or like granuloma or something like that. But no, it was a web, and then the big differentiator was knowing that the web occurs in the upper esophagus and the rings tend to occur in the lower esophagus, distal, I should say. So those are different types of mechanical obstructions, just simple basic obstructions to food going down. And that sort of obstruction, again, whenever you swallow a bite of food, particularly a large bite, if there is a kind of a bump in the road of your esophagus, obviously that's going to clue you in, ping the sensation that there's something there. You can feel somewhat what's going on in your body, and that's where this sensation of dysphagia comes from, is that obstruction. Let's talk about Zenker's diverticulum. That's the takeaway from this couple of paragraphs here. You need to know what Zenker's diverticulum is. And you specifically need to know that it's basically a hole in the cricopharyngeal muscle. So remember, you've got your cricoid cartilage and then your thyroid cartilage. And your thyroid's the big boy, and then the cricoid cartilage, I think, is underneath it, right? And then the cricoid one is the one that's kind of like the signet ring. And remember that your thyroid cartilage is open to the back, but your cricoid cartilage is closed at the back. And so it's the attachment point for lots of muscles, specifically some muscles that manipulate the vocal cords. So that's the topography of the posterior larynx that we're thinking of here. Now, understand that your esophagus is right behind your larynx. Bingo, that's why we talked about your posterior larynx. Why would I bring that up? Because your esophagus is right there. So if you have a problem with your posterior larynx, what that kind of means is that you got a high risk of having a problem with your anterior esophagus. So Zenker's diverticulum, also known as pharyngoesophageal diverticulum, an outpouching of mucosa and submucosa through the cricopharyngeal muscle, arises from the posterior hypopharynx, which is right above the larynx, immediately above the upper esophageal sphincter. I've got a couple pictures of it right here. So here, notice, here's the mandible, right? And then here's the airway. And then I'm highlighting in red right here. Here's your trachea going down, and then you've got an esophagus too. And then I'll put it in green here, this obvious big shadow with a lot of dye in it. It's just it's a cul-de-sac, and it's a pouch, and it's holding a lot of dye in it because there's nowhere for it to go. So you had this patient do a barium swallow, and then you waited and waited and waited. Then you took an X-ray, and so all the dye is lighting up because there's a hole in the cricopharyngeus muscle, and it's leading to this pouch that's hanging down like a water balloon that has not been filled with water, but now it is filled with some water. So that's exactly what we're looking at. Same thing here on the right. Here's the mandible in green, both pictures. You can see the upper and lower rows of teeth here. And man, that's a pretty big pouch right there, holding all that dye. And so the pouch is branching off of the esophagus. I know I talked a lot about the airway. I don't want you to think that this is branching off of the trachea. No, this diverticulum is branching off the esophagus. Back to the text, it fills up with food. We just saw it. We just saw this thing load up with dye, but food, can't you imagine food can do the same thing? Because you chew up food to the point where it gets, it's a semi-liquid by the time you swallow it. So food can get in there. And that's commonly the presenting symptom of this Zenker's diverticulum is patients just going to spit up some just absolutely rancid, partially digested food out of the middle of nowhere, like RKO out of nowhere. Zenker's diverticulum out of nowhere. This patient will just be laying in bed and they'll spit up some food. So regurgitation is the big symptom here, not really dysphagia. Now we've got achalasia. I love saying that word. Nice word, very aesthetic word, achalasia. Before we really get into it, I want to mention that this has a correlation with Chagas disease, which is spread by Trypanosoma cruzi. Remember, that's Che's gas, the sketch. And what's the bug that's associated with that? It's the kissing bug. It's the reduviid beetle. And so you get these bites around your eyes, right? You can swell up and get that thing called Romanes sign. Well, they can give you a myocarditis if it gets really bad. But then one of the things that's a little bit more common is they can give you achalasia, this Chagas disease. You can get achalasia from it. And it's because the neurons of the lower esophageal sphincter are just going to get capped off by this parasite. So that's exactly what achalasia is. It's a neuronal problem leading to impaired lower esophageal sphincter relaxation and loss of peristalsis. So if you have impaired relaxation, what's that mean? You're tense. You're like you plus 10 cups of coffee. Like that's achalasia. So your lower esophageal sphincter that is connecting your esophagus to your stomach is just not letting go. So what happens? Well, food can't get into your stomach. And so it ends up looking like this, and we call this a bird beak esophagus because like way down here, that's your lower esophageal sphincter that's just a clenched fist. And that's how wide your esophagus can dilate to accommodate food that can't get into the stomach. So that's what it is. So why do you get it? Again, something happens to the neurons down in your myenteric plexus. And a plexus is just a grassroots network of neurons that's kind of interconnected and laced together. And a plexus is a word that rhymes with Lexus. And so Jay-Z likes to use the word plexus a lot because he also likes to use the word Lexus a lot. And the myenteric plexus is particular to the gastrointestinal tract. And your gastrointestinal tract has an astounding level of neuronal functioning. And there's a lot of different signaling peptides, neuropeptides down in your gut that are unique to the digestive system. Things like VIP, vasointestinal peptide, and other things like, why am I blanking? GLP glucagon-like peptides. So these things are neurosignaling molecules that your nervous system will use to talk to the smooth muscle of your gut to tell it, hey, contract, you got food in you, or hey, chill out, there's no food here, you don't need to move. So that's the purpose of this very complex enteric plexus. So depending on where you're at in the plexus, right, you're normally going to be either loose or tight. And so if you're just a stretch of tubular GI tract, you're normally going to be loose because, well, you don't have any reason to be tight. But then if you're a sphincter, are you going to be loose normally? God, I hope not. You know, it's like, imagine if you were just walking around, you get up out of bed one morning and every sphincter in your body is loose. Oh God, that's a terrible thought, you know? So you want your sphincters to be tight. So for your sphincters to be tight, they've got to just, but then you also want them to be able to loosen up when necessary. And so while they are going to be maintaining a pretty tight tone normally, your sphincters have to be able to open up, you know, abracadabra at a moment's notice when need be. So achalasia is when your lower esophageal sphincter can't open up at a moment's notice when need be. And the two specific chemicals that tell your lower esophageal sphincter open up are nitric oxide. Oh, okay, yeah, that makes sense. Nitric oxide dilates everything. We know that. And vasointestinal peptide, vasoactive intestinal peptide. So recognize NO and VIP on a test question. And also understand that you're going to see eventually a loss of peristaltic function as your esophagus fills up so much to the point where it's like the muscle can't move. It's stretched to the point where it's like peristalsis. Yeah, right. Like it's got such a heavy load on it, it can't move. So clinically, achalasia presents with a dysphagia to solids and liquids. And that and liquids means that if you give patient a cup of Kool-Aid, they're not going to be able to get that Kool-Aid down their throat very well because it can't get into the stomach because that sphincter's tight. So they're going to report the subjective experience of, oh, I don't feel like I swallowed that properly, even when they just drink a cup of water, you know. And then what's going to happen if this gets severe or if they eat a large meal and they're symptomatic during the meal postprandially is they're going to have to spit up a lot of this food because it's going to have nowhere to go and they're going to have so much food up in that esophagus that, like, if they even move around, you know, like you bend over, you're going to be leaking a little bit of food out. So that's the two big symptoms: dysphagia for solids and liquids, and then a little bit of regurgitation. And you should understand, for the purposes of our tests, it's the only thing on this SDL that's got a dysphagia for liquids. Diagnosis, you're going to give them a cholecystokinin test. You do barium swallow too. That wouldn't be a bad thing to order. You know, it's not like you got a cholecystokinin test in every department in America. Also, you want to know that achalasia, big correlation with squamous cell esophageal cancers. And that'll be good to recognize. Quick aside, there's only two types of esophageal cancers you need to know about for our tests. There's a squamous cell and there's an adenocarcinoma, adeno being a glandular cuboidal epithelial neoplasm. So that makes life pretty easy for us. So achalasia is correlated with squamous cell esophageal cancers. Now we're talking about hiatal hernias. This is another purely anatomical pathology. Really great diagram down here, top of page 6. Just to set the scene for what's going on, like all the anatomy here. It's really tough to teach you anatomy over Zoom, you know, but found a great test question. Said, 45-year-old man presents with long-standing heartburn and dyspepsia, which is basically dysphagia. X-ray of the chest shows a retrocardiac gas-filled structure. This patient most likely has blank. And the answer was hiatal hernia. And the gas that you see behind the heart the emptiness on X-ray is this pouch of stomach that's pushing up through the diaphragm. So the esophagus is going to go through the diaphragm at the level of T10, I want to say. Take a guess right there. Use the force Luke, you know, but I think the diaphragm, the esophagus penetrates it at the level of about T10, and then the stomach is right on the other side. So the esophagus can contract longitudinally. We've established that. So it can shorten its length, is what we're saying. Well, if the esophagus shortens its length too much, it might just pull the stomach up through the diaphragm when it contracts. So a very forcible contraction can lead to a hernia of the stomach through the diaphragm. And in fact, that's the mechanism of 95% of your hiatal hernias is going to be esophagus contracts lengthwise and it pulls the stomach up and uproots it, kind of like pulling up a plant from the ground as it contracts. Now, the other 5% is going to be this true hernia where you actually do have a separate pathologic, you know, non-normal, abnormal hole in the diaphragm, and you can get a pouch of the stomach that bulges up through that sort of hole too. And what sort of things could cause diaphragmatic trauma? Just extreme bouts of coughing, extreme bouts of sustained vomiting, straining against pressure. So sliding hiatal hernia, that's this dude in the middle here, the sliding hernia. It makes sense. Stomach is just sliding upwards. Is characterized by displacement of the gastroesophageal junction. And the gastroesophageal junction is really a histologic landmark rather than a gross landmark. You can kind of tell what it is grossly, but really you're looking at the cell types under a microscope. And it should make a lot of sense to you. We shouldn't have to connect any dots that this sliding hernia can give you GERD, gastroesophageal reflux disease, because, well, okay, normally the diaphragm is constricting and that lower esophageal sphincter is constricting around the stomach and holding all your stomach acids down in your abdomen. But if part of your stomach gets into your thoracic cavity, well, then it's, you know, it's just a real quick trip up into your oral cavity now that it doesn't have to go through the diaphragm. And so that can give you the symptom of heartburn, you know, and that's the patient's experience of acid reflux. And if your heartburn's chronic and it's got a good reason, if you can deduce the cause of the heartburn, that's when you call it GERD. So this is another obstructive sort of esophageal pathology, meaning that you're going to see dysphagia to foods, but not to liquids. You're still going to be able to drink. Let's talk about esophagitis. Here's a test question. You got five different types of esophagitis. Well, it looks like A through E to me. So you can get esophagitis from GERD. Pretty sure everybody watching this will understand what gastroesophageal reflux disease is. It's basically chronic repetitive heartburn for a physiological cause. And that cause can be an infection. It could be a loss of certain cell types lining the stomach. It could be due to particular foods that you consume, creating a particularly acidic environment in the stomach. It could be due to eating like greasy and fatty foods, you know, that the cells of your stomach really don't agree with, or maybe if you just eat something that you've never really eaten before, if it's something your body's unfamiliar with, you can get some stomach contractions. And if that lower esophageal sphincter is loose, well, then acids from your stomach can just splash up from it. Splash is a good word to use, and just get into your esophagus, and then you feel that, you know, and that feeling is called heartburn. So understand that esophagitis is generalized inflammation of the esophageal mucosa. So if you've got stomach acid splashing on the inner walls of your esophagus, yes, that'll give you an esophagitis. And it might not be an esophagitis after one incidence, you know, but like this happens 30 times in 30 episodes of heartburn later. Yeah, your esophagus is probably not liking your stomach. So what's going on succinctly is the patient's going to present with heartburn, or maybe they, you know, won't even go to the doctor. It's just heartburn, take some Tums. So they'll have heartburn, but then eventually it'll turn into dysphagia. And so the patient will say, well, I had some heartburn, past tense, and I still have some heartburn, but now I'm really disturbed by the fact that like food's not going down like I feel it should be, and I'm kind of feeling a bump whenever I swallow. And so what you're going to interpret that as is, well, okay, heartburn, GERD, check. Esophageal reflux, check. Why else would they have heartburn? Not a lot of other causes for that. It's the most common. So why do they get this dysphagia? Why do they transition into this dysphagia? And it's because the acid from the stomach is splashing up onto the insides of the walls of the esophagus. And remember, I used the term, what was it? Hyperplasia, reactive hyperplasia. That's what's going on here. Your esophageal mucosa gets splashed with acids, and then it has a reactive hyperplasia, and the cells of your mucosa multiply, and they narrow as they multiply because they're growing. There's more cells. So all of a sudden, your esophagus, at the level at which it's getting splashed with stomach acids, is thickening, and that thickening creates a ring or a stricture of pathologically multiplying tissue. And so that's how you get esophagitis out of it. Two big risk factors: hiatal hernia, obesity, raise the risk of gastroesophageal reflux disease. Hiatal hernia should make sense. Again, you're looking at this here, you know, it's like it's so much easier for stomach acid to go upwards whenever it doesn't have to kind of make it through the bottleneck of the diaphragm. And then obesity. Beats me. The two dominant pathophysiologic mechanisms causing reflux are lower esophageal sphincter dysfunction and delayed gastric emptying. This is a little bit of a wonky section because well, you'll find out. Lower esophageal dysfunction talks about burping, and it says transient lower esophageal reactions are parasympathetic reflexes. So that's good to know. That's a really good takeaway. Now you understand, all right, what's a burp? It's a parasympathetic reflex. And during a burp, you have to have your lower esophageal sphincter relax and open up. And then you also have to have your upper esophageal sphincter relax and open up. You also have to inhibit your diaphragm. And then you have to contract your esophagus. So those things have to happen in order for you to burp. And if those things happen, well, whenever your lower esophageal sphincter opens up, guess what can splash up into your esophagus? Stomach acids. Okay, so those dots get connected there. But that's not really what the text is saying. It's more so something that like you have to infer. So that's why I say it's a little bit of a weird section there. Delayed gastric emptying. Again, there's a lot more to delayed gastric emptying than what's going on here, because different types of foods are going to cause like what you swallow to stay in your stomach for varying amounts of times. If you just take like simple sugar, if you ate sugar cubes, your stomach would empty itself very, very quick. And then the more proteins and the more fats that you add to that meal, you know, it's going to take proportionately longer and longer and longer compared to that simple carbohydrate meal for your stomach to empty. So what you eat the proportions of the macronutrients you eat contribute to the speed at which your stomach empties. Now that's normal. What about pathologic delayed gastric emptying? Well, if you eat a whole lot of food, and I'm talking like thousands of calories at once, your stomach it's just not going to be able to empty itself in 30 minutes to an hour. You know, it's going to take a little bit longer. That's not really pathologic. That's something I really added in. But over time, you know, it's like your stomach gets used to that. And eating a big meal for sure would make you more prone to develop GERD, because it's like, well, the risk of, or the likelihood that acid just, you know, bops upwards and splashes up into your esophagus is raised if you've got, you know, this much food in your stomach, versus if you've got like a smaller amount of food, you probably don't have as much stomach acids, you know. And so the amount of acids that you're making is going to be proportionate to the food that you're putting in your stomach, because your stomach's going to adjust and adapt and then start making whatever it needs in terms of secretions. So yeah, overeating could lead to GERD. Infection, acute stomach infection, H. pylori, by far, in a way, being the most common. Anything that impacts the secretory cells lining your stomach can lead to GERD, and that's not really mentioned in the text, you know. But again, when we're thinking GERD, we're thinking acid reflux, and so anything that makes your stomach make more acids, and irritation of that lining mucosa can sure cause it to make more secretions. You can have a bowel obstruction that delays gastric emptying. Maybe the reason that your stomach can't empty is because it's trying to empty, but there's nowhere for the food to go because your bowel's full. That's a cause of delayed gastric emptying. And then I'd say the most like testable, just because it's common and you wouldn't necessarily think about it at first, it's probably a diabetic neuropathy. And there's a couple of nerves going down to innervate your stomach, namely the vagus nerve. There's a whole plexus down there. And so a diabetic neuropathy means that the ability of your nerves to conduct an action potential is going to get impaired as a particular nerve receives more and more and more damage due to local hyperglycemia. And the damage in diabetic neuropathy is mediated by advanced glycolation end products, which is basically proteins with glucose stuck onto them. And then these proteins have a tough time getting ubiquinated and properly disposed of because of the multiple glucose tags that are on them. And an example of a glycolated protein is hemoglobin A1C, but really any protein can get non-enzymatically glycolated. And so the more sugar you have in a cell, in an environment, in your bloodstream, the more likely you are to go around glycolating all these proteins. And they can add up, and it's just crud accumulating in the cell, and that's the mechanism of damage in diabetic neuropathy. So that can also cause a delayed gastric emptying due to your impaired ability to send the signal down, hey, yo, open up, sphincter, it's time to pass this food into the duodenum. Nope. We talked about some pathology here. Looking at reflux esophagitis. There's some scattered eosinophils. Kind of hard to point them out. You know, they're gonna be glowing red on a color section, but really they're going to be the small, dense cells with scant cytoplasm, because they're lymphocytes, like that. So most of these eosinophils you can spot even without having them be in red. That's an eosinophil. But these are scattered eosinophils, okay? And that's going to be really eosinophils are kind of a hallmark, but it's like you remember that dude on what was it, Vine or something? You remember that chef that would sprinkle salt up on his food like that? He just like cut up all that like flank steak or something and then just grabbed the salt. And he was like so cool, yeah. And it's like that's the eosinophils in your GERD. Okay, you don't have a lot of eosinophils. You have a sprinkling of eosinophils. And that's going to be compared to your eosinophilic esophagitis, which we're about to get to after we talk about Barrett's esophagus. So again, esophagitis due to GERD, what's your symptoms? Heartburn. It can progress into a dysphagia. If it is, then you ought to start worrying. If a patient goes from heartburn to dysphagia, that's when you say, okay, maybe there's a ring or a stricture down there, but you can't rule out cancer. So if there's anything else in their history, like 10, 15-pound weight loss, or maybe they're pooping out blood, then that's when you start suspecting cancer along with this GERD presentation. We talked about a stricture. It's a narrowing caused by a persistence of ulcers causing an inflammatory and sclerosing damage of the esophageal wall deep to the lamina propria. So again, acid splashes up. Your cells don't like that. They get agitated. You get reactive necrosis. And so the cells start multiplying. You get hyperplastic. And there's a lot of extracellular tissue that gets thrown down in that necrosis as well. And that's your dysphagia. Barrett's esophagus. The gist of this pathology is that you're going to see goblet cells in the esophagus, and they're going to be secreting mucus, and they're going to be doing this because you get so much acid splashed up into your esophagus that your body starts to think, oh, hey, this is my stomach. Why is my stomach not secreting anything to mitigate that acidic environment? And so your esophagus will histologically turn into your stomach in order to buffer the pH of the stomach acids that are popping up into it continually. And so again, Barrett esophagus really only happens to patients with GERD, because if there's no stomach acid popping up, there's no reason to grow some mucinous glands in your esophagus. And what do these glands look like? Well, histologically, they're columnar cells, and you can see a nice little, oh, that's a beautiful gland right there. That is a textbook gland. And you don't even need to zoom in to see the goblet cells there, but they're marked with an arrowhead right there. Those big washed out ovular cells, those are goblet cells. And so if this is in the esophagus, that's not normal, because you should have a squamous esophagus all the way until the stomach. So what's important to know for the test is that there is a big correlation with esophageal adenocarcinomas and Barrett esophagus. So what was associated with squamous carcinomas? Do you remember? Because I've just been talking. We did have something up here associated with squamous carcinomas. There it is, achalasia. So achalasia, squamous cell cancer of the esophagus. And then Barrett esophagus, association adenocarcinoma of the esophagus. We're going to diagnose this metaplasia by taking a biopsy, because, like, you know, what are we going to do? See columnar cells with an endoscope? So risk factor, smoking. That's it, really. And you're going to see salmon type patches. Salmon pink is a nice descriptor to know, and you probably ought to be able to recognize grossly this salmon pink metaplasia. So jokes on me, actually you are going to be able to see it on endoscopy. And it's going to be salmon pink. This is a good cartoon here showing you that, you know, esophagus is going to be squamous, and then at the gastroesophageal junction, all that squamous stuff is going to turn to columnar, and it's going to start secreting stuff for the stomach. And then the farther and farther up that columnar mucosa travels up the esophagus, the worse your progression of Barrett's is. Let's talk about eosinophilic esophagitis. It's a chronic esophageal inflammatory disorder, allergic in nature and of unknown origin. And most patients are going to have a history of a bad allergy or asthma or allergic rhinitis or some sort of gimme in the question stem that lets you know, hey, this person is prone to get eosinophilic esophagitis. Fairly common condition, not super common, but enough to where it should be on your differential. Majority of patients are young adult men. Big symptom is intermittent dysphagia, not a terrible dysphagia, but maybe impaction, the subjective sensation of food, not just a difficulty going down, but like food gets to a certain point and then it gets stuck. And then maybe if you're lucky, it will go down. So that's an impaction, not just slow, but stuck. if you look at eosinophilic esophagitis on histology, I put a circle around all these eosinophils, but like these things are so popping that you can see them even in black and white. Remember, your eosinophils compared to epithelial cells, squamous cells, they're going to be smaller and denser, and they've got these almost perfectly round nuclei in most cases. And I call them poppy seed nuclei. They're like poppy seed bagels. And so that's a circle around a big follicular-like nest of eosinophils in this esophagus biopsy. So this is nothing too complicated here. Now let's talk about infective esophagitis. And we're talking about Candida, herpes simplex, and cytomegalovirus. And I want you to know that all these three are AIDS-defining infections. And so I actually didn't understand until today. Actually, I did some research into, well, why do we care what an AIDS-defining infection is? You know, because it's like HIV, AIDS. I mean, there's a difference, but it's like it's not self-evident why we should care about it, you know, because at the end of the day, it's just like a health condition. But really, you want to know for purposes of keeping track of the development of HIV into AIDS in developing countries. Because, you know, we diagnose AIDS based on T cell count, right? A T cell count less than 200 is diagnostic of AIDS. And that's all nice and good in developed countries. But like, if you're out in some place where it's like, how am I going to get my T cells counted? Well, a nice, easy way to do some epidemiology involving HIV/AIDS is to just measure the prevalence of AIDS in the area by the prevalence of these AIDS-defining illnesses. So that's part of the reason why this list of AIDS-defining illnesses exists, is so that we can monitor this disease globally and have a better picture and understanding of the evolution of HIV into AIDS. And the other reason is billing, of course, you know, and government money. But I won't get into that. So candidal esophagitis. I think as Golion said, there is no way in God's green earth that anyone will ever get Candida esophagitis unless they are really poorly immunocompromised. And typically it's going to happen with AIDS patients with CD4 counts under 100, which is super low. Candidal esophagitis presents these elevated white plaques, the white snowy-like color, very characteristic of Candida. And it's going to essentially line the esophagus with pseudomembranes, which is going to differentiate it very easily from herpes, because with herpes, no pseudomembranes. Cytomegalovirus, no pseudomembranes. No, do not think that. But Candida, yes, pseudomembranes. And the membranes are made out of what? The fungi, a lot of neutrophils that just netted and exploded, right? A lot of fibrin, other immune cells. So you run the risk of disseminated candidiasis. We know Candida can turn into a pulmonary infection too, get into the bloodstream. But hopefully you catch this Candida esophagitis before that, and hopefully the patient is responsive to either fluconazole or capsofungin. So herpes esophagitis, this is the big one from this lecture, because herpes and cytomegalovirus esophagitis present a lot more similarly to one another than they do to candidal esophagitis. Now, herpes simplex, HSV1 and HSV2, understand that primary herpes infection is a full-blown all over the body type thing. You've got a lot of lymphadenopathy. You've got some big swollen lymph nodes. If you've got HSV1, and also depending on the route of infection, if you've got it orally or genitally. If you get it orally, you're going to see a lot of swollen cervical lymph nodes, and that's typically HSV1, but it can be too. And you're going to see some like cold sores. That's the characteristic herpetic lesion. And then if you get HSV2, you're going to see cold sores on the genitals, and you're also going to see some sort of inguinal lymphadenopathy, most likely. And so if you have herpes, you're going to also have, you know, like fever. You're going to have absolutely malaise. You're going to feel like crud, and it's going to be a total body infection, and it's going to last for a couple of weeks, maybe a month. And then herpes eventually will self-resolve. But herpes doesn't go away, and that's what you got to understand when you're talking about herpes, is that all of these herpes viruses go latent. They love to go latent in particular cells. And depending on what family of herpes virus you're talking about, it's going to like to go latent in a particular type of cell. Now, for cytomegalovirus, CMV likes to go latent inside the immune system. So it's going to go latent inside T cells, B cells, and monocytes, macrophages. But herpes simplex does not have a tropism for the immune system like it has a tropism for the nervous system. Herpes simplex is going to go latent inside the ganglia of different nerves, cranial nerves, and even sacral nerves. And VZV can go latent, in any of the sensory ganglia, your dorsal root ganglia. So herpes simplex has a predilection for nerves. And then, where can I go after this? So we've talked about generals, overview of the herpes virus family. Let's just talk about herpes simplex. Herpes simplex, you're going to see multinucleated giant cells, and they're going to have some internuclear inclusion bodies. They're going to be pretty eosinophilic, and you're going to diagnose your herpes simplex with something called a Zenker prep or a Zenker smear. And you're going to just swab an oral lesion and scrape it and look at it under a microscope after you prepare it. And it's going to basically, if you see giant cells, you're going to say, yes, that's pretty much herpes. Cytomegalovirus is a little bit different in its diagnosis. You're not going to see multinucleated giant cells. You're not going to Zenker smear it. It's heterophile antibody negative. Shoot, I'm trying to remember how to diagnose CMV. My gut's telling me, you're going to PCR for it, or you're probably going to like blood antigen for it. But really the diagnosis is going to be made on biopsy of any lesions that you see. If you biopsy cytomegalovirus lesions, you do not see giant cells. You do see a ton of owl-eye inclusion bodies. That's it. That's the main diagnosis. It's a histological diagnosis. And so I want to tell these two apart. So let's look at some images. Now, herpes simplex esophagitis, this is where it gets kind of tricky too. Remember we said Candida has a pseudomembrane. Well, herpes simplex and cytomegalovirus, they present with ulcerations, ulcerated esophaguses. And HSV is going to give you these punctate or volcanic or hole punch sorts of ulcerations. You can really tell, like right there, it just looks like somebody took a hole punch and just, I mean, it's a very circular lesion. These lesions are so circular. Like right there, great example. Right there, great example. Right here, versus cytomegalovirus, which has some traditionally linear lesions. And I've got a dude from Sketchy Micro up here in the upper right. Remember, we've got a checkout line with bloody linear lines on it. That's representing our linear esophagitis and CMV. Again, it's an AIDS-defining illness. That's why dude's got a cane. So here's an example of linear. And I looked at a lot of Google images to find some decent photos of linear cytomegalovirus, because they just don't look that linear to me. But they are ulcerated. And while it's not perfectly linear, it's at least like oblong or like rod shaped or hot dog shaped. So you can tell that this is not, even if it's not the most linear line, it's not a punched out hole lesion, right? It's not a circle. So that's going to be your gross, that's going to give you your gut feeling one way or another between herpes virus 1, 2, or cytomegalovirus, which is herpes virus 4. So let's look at the cell preps to Zenker smear. Again, you're going to see multinucleated giant cells, and we're really seeing a big syncytium of cells along the left side of this picture on the left here. Those are not normal epithelial cells, you can tell. And then on this image in the right, here is a lower left quadrant. Here is a big multinucleated giant cell. Here's another big multinucleated giant cell. Here's a third looking multinucleated giant cell, and these things are just not nice. And in contrast, I'll try to take some blue and highlight this normal epithelial cell just so that you can see, you know, it's like, yeah, that is very clearly demarcated. That is clearly one cell. Like this here, that is one cell. But the multinucleated giant cells, there's a lot of nuclear overlap, and that's going to allow you to identify these cells. Again, this is HSV 1 and 2, and this is a Zenker prep. Looking at cytomegalovirus esophagitis, you don't see giant cells. What you do see are owli inclusions. We're talking like Drake, OVO, you know, owls. So there's your owli. There's your owli. There's your owli. And I know I said that herpes has a tropism for neurons. It likes to go latent within neurons, and CMV within the immune system. But in the initial infection, these things have a tropism for epithelial cells. So you're going to see these inclusions within epithelial cells too. So that's CMV, that's your owli inclusions. Getting back to the text. Now, anytime you have an ulcerative esophageal lesion, you can get this symptom called odynophagia, which is a new word for me, and it just means painful swallowing. And so if you have ulcerations, and you can see this in GERD too. Remember we said when GERD transitions from heartburn into dysphagia, it's associated with a lot of ulceration of whatever mucosa is getting splashed by acid reflux. So that can give you odynophagia as well. It's different from dysphagia, which is just subjective experience of weird swallowing without a lot of pain. So please remember herpes, we're going to treat it with acyclovir. CMV, we're going to treat it with ganciclovir with a G. And if either of these boys are resistant to their initial treatment, we can go to foscarnet and cidofovir, which are going to be pyrophosphate analogs, which get up into DNA polymerase of these different viruses, and they plug up the machinery and they stop it from reproducing itself. So our last pathology of esophagitis is our chemical esophagitis. I personally think that this is a pretty relevant section because alkaline agents and acidic agents are going to have completely different effects. Alkaline agents, when swallowed, cause liquefactive necrosis, and acidic agents, when swallowed, produce immediate coagulative necrosis. And I really can't explain that beyond that. I'm excited to learn more about this in time, but this is the sort of scenario that you see whenever somebody drinks bleach or Tide or some sort of other cleaner. Cleaners tend to have a lot of alkaline agents in them. Acids, hydrochloric acid, sulfuric acid, back to the OChem lab. So these things can be ingested accidentally or intentionally. And that leads to a lot of creative and crafty question stems. Let's talk about varices. You see esophageal varices. Well, all right, we've seen varices before. We've seen varicose veins in the calves, right? So varicose veins in the esophagus are very similar. And they're going to be caused due to hypertension. And they're varicose veins specifically of the left gastric vein most of the time, which is draining the distal or the lower esophagus. And the left gastric vein is draining the left esophagus into the portal vein. And the portal vein is draining into the liver, which is draining into the inferior vena cava. So if there's hypertension in any of those components along the pathway of venous blood back to the right heart, well, then you're just going to see venous backup. And we've seen this because we've done a whole lot of right heart failure, you know, and we know that edema is going to be a manifestation of high hydrostatic pressure whenever there is a fluid backup way down the line. So esophageal varices, fluid backup. What's the real bad risk here? Well, they could rupture. And then what's that going to look like clinically? Well, the patient could vomit up blood because they could rupture under the setting of intense vomiting or retching. They could also, if it's less acute, it could lead to melena, which is dark, bloody stools, and so that could be a presenting symptom of a ruptured esophageal varicose vein. And last but not least, important to understand that these veins typically dilate as a response to hepatic hypertension, not right heart hypertension. Right heart failure's got to get pretty bad to see some esophageal varices, but portal hypertension, liver hypertension, well, that can be caused by cirrhosis, and that can also be caused by cirrhosis can be caused by a few things, namely alcoholism and non-alcoholic fatty liver disease. So either of those two things over time can compound into a cirrhotic, scarred liver that is not going to be able. There's going to be so much scarring in that liver that it's not going to allow the blood vessels in that liver, the veins in that liver, the room to stretch and fill up and engorge with blood following a meal. And so whenever those veins in the liver are compressed due to the surrounding fibrosis and scarring, well, that pressure backs up. And so you get a high hydrostatic pressure in the veins downstream. Again, one last time, it's the left gastric vein supplying the lower esophagus. So let's talk about Mallory-Weiss Syndrome. We said that esophageal varicose vein can rupture. Well, the inside of your esophagus can rupture too. So that's how I'm trying to tie it together. You know, this is also a hemorrhage into the lumen of the esophagus. And before I say anything else and make myself look like a fool with my words, here's a picture, because this is worth 1,000 of my words. That's a Mallory-Weiss tear. That's a Mallory-Weiss tear. So something happens, strains and stresses, or creates a super high pressure within the esophagus. And as a result, it's just a blood vessel ruptures. We've seen this on the conjunctiva of the eye. You know, you might see a petechia in a muscle belly if you're working it particularly hard. So this is the same concept here. It's a focal hemorrhage. Let's go back to these slides. They're most common in older patients, and they're associated with hematemesis, which means vomiting blood, coughing up blood too. You might see that's hemoptysis. So the strong and obvious association is going to be vomiting. And a catch that I want you to make, or a quick association I want you to catch on a question stem, is going to be the bulimic patient. Maybe it's a teenage girl, or maybe it's a competitive athlete, a wrestler, a bodybuilder, someone like that who's very image preoccupied, and they're going to be throwing up because they've got this eating disorder that does involve eating a mass amount of food and then throwing it right back up. So that's where you can see Mallory-Weiss syndrome, which is the accumulation of multiple Mallory-Weiss tears. And then another cause of vomiting, and then retching too, and retching basically means dry vomiting, is alcoholics, or not even alcoholics, you know, just dumb college kids having like a fifth of Cuervo before they even go anywhere, before they even leave their room. They've already had like a fifth of dang Jack Daniels honey, and it's like they wind up on the floor somewhere, and it's like they're retching, they're dry vomiting. So alcohol can give you Mallory-Weiss too. So alcoholics will develop this syndrome, but the individual tears, you know, that can accompany a singular episode of vomiting. Esophageal neoplasms. I love this section of the SDL. Why? Because I'm about to do it in 1 minute. So what symptoms are going to make you suspect cancer? Patient loses a lot of weight. In the gastrointestinal system, patient is pooping out blood. You got two types of esophageal cancers. You have squamous cell carcinomas, malignant cancers, and then you've got adenocarcinomas, malignant cancers. So squamous cell carcinomas are going to be flat and have a lot of keratin pearls. Here's a keratin pearl. There's no nuclei in it. It's pearl shaped. These cells, do they look cuboidal to you? Do they look like, are there any glands in this picture? No. Is that an adenocarcinoma? No. All right, this picture over here, you see any glands in this picture? Please say yes, because I see some glands in this picture. How about these cells here? Do the cells that I've boxed in, do those look like cuboidal cells to you? They should. They're not squamous. They're not flat. And they're surrounding a lumen. And typically you've got cuboidal or columnar cells surrounding a lumen. So that's your adenocarcinoma. And then, well, how do you make the differential? Well, you won't even have to look at the histology sometimes, because adenocarcinoma occurs in the distal 1/3 of the esophagus, right? So distal meaning close to the diaphragm, close to the stomach. Squamous cell carcinoma, most esophageal squamous cell carcinomas involve the middle and upper thirds of the esophagus. So that's it. That's the differential on an in-house test question. And obviously, in real life, keep your suspicions open. But on a multiple choice exam, you know, they are going to give you the esophageal cancer. And I don't want you to say transitional cell carcinoma, because there are no transitional cells. There's no transitional epithelium in the esophagus. There shouldn't be. You know, that's wrong if there is. So don't pick that as an answer, because I saw it on a question. Genetically, you know, it's like they didn't really highlight any genes in this text. Okay, P53 is highlighted for squamous cell carcinomas, but P53 is highlighted for both. You know, like P16E4A, that's highlighted for both. So there's nothing particular genetically separating squamous and adenocarcinoma. They're just cells that arise in different places. And of course, remember your association. Squamous cell carcinoma associated with gastroesophageal reflux and Barrett esophagus. Remember, you can't get Barrett esophagus without GERD. Now, adenocarcinoma, please remember that it's linked to GERD, Barrett esophagus, but also achalasia. Give this one more scan to make sure I'm reading it right. Tumors of the upper third of the esophagus metastasize to cervical lymph nodes, supraclavicular lymph nodes. Cancers of the lower third metastasize to retroperitoneal, celiac, left gastric nodes. Metastases to the liver and the lung are common. And of course, we're saying squamous cell carcinoma, adenocarcinoma, malignant invasive cancer. So metastasis is, like, you know, fairly likely. So I'll highlight that whole section there at the bottom of page 14, just because it's telling you that there are a lot of different places you ought to suspect NETs, and that's important for whoever's job it is to deduce the sentinel lymph node when it comes time to stage this tumor. So I want to conclude by just mentioning one more time, if we've got a dysphagia to solids only, we're thinking it's an obstructive pathology. There is something in the pipeline of your esophagus that is mechanically impeding the flow of a bolus of food down that lumen. If we're seeing a dysphagia to liquids, we understand that there is some sort of conduction problem in the nervous wiring of this anatomical region, usually impeding peristalsis, but can also involve the lower esophageal sphincter if it's achalasia. That's it.